So, a very good afternoon, respected directors, faculty member, dear students and audience. I, Dr. Sant Kumar Verma, Associate Professor, ISF College of Pharmacy, Moga, would like to welcome my senior, Dr. Akram Ahmad, Burns researcher and research manager, the Children's Hospital at Westmead, Sydney, Australia, and founder and CEO of Academically Proprietary Limited, Sydney, Australia. Sir, welcome you on the online platform of ISF College of Pharmacy for delivering a talk on patient references, measurement, and application in clinical practices. Sir, again, I heartfully welcome you on ISFCP online platform.
And thank you so much, San.
Over to Akram. Yes, yes.
Okay. So, hi everyone. This is Dr. Akram here. So, I'm basically an Indian pharmacist, completed my diploma in pharmacy, bachelor of pharmacy in PharmD from India. And then I did my PhD from University of Sydney in Australia. I have around 11 years of teaching experience for pharmacy practice and clinical pharmacy in India, Malaysia, and Australia. So basically, you might be don't know about the patient preference. You might be here. This is the first time. I also heard the first time when I went to do my PhD in Australia, because these terms are not very familiar or using in the low and middle income countries. Mostly the high income countries, they are working a lot of work on the patient preferences. Okay, so today I'm going to discuss about what is the patient preferences, how you can measure, especially in the clinical practice. So if any medical doctor, how he can implement this practice in his daily practice, and what are the advantages regarding this patient preference. So I will discuss basically the few things, like one of the background of this study, and then methods, how we can basically conduct this kind of study, also called DCE or discrete choice experiment, and we'll also see the result, how we can analyze the data, and then conclusion about this study. So this is basically from University of Sydney. So I completed my PhD from University of Sydney. So this is the medical school, and you can see this is at the end. This is a pharmacy school of University of Sydney Pharmacy School. So this is the first school established in Australia, and one of the oldest university in Australia, and I can say around the world. This is around 1849 they established the university. This was the first medical school they established in Australia, and later they also opened first pharmacy school in 1899. This building is very old, and my office was somewhere here. I completed my PhD around 3.5 years. I was in University of Sydney. I'm still associated with them as a tutor or a lecturer there. So basically, I'm I did my PhD on diabetes. So I basically do this experiment on diabetes patients. So Indians are living in Australia. So they are using a lot of other medications apart from their medical doctor are prescribing for them. So basically, they are not adhere. They are basically non-compliant to their medications. There was a question basically in Australia that why these Indians are they have very basically high prevalence of diabetes and uncontrolled diabetes and a lot of complications among Indian population. And what was the reason for this? That's why we planned for this study in this population. So if you see in Australia itself, 1.2 million, around 12 lakh the patients are living in Australia with diabetes. And if we talk about the Indians, so around 2.6% are Indian currently living in Australia. So it's growing every year. So this is the data on 2019, and after that there's no data, but I can say about maybe 700,000 plus now Indians are living in Australia. So if you see here the one figure that they have very, very high prevalence among the Indian population. So if you see here, this the normal population have a 7% population have diabetes, but Indian population have around 14.8. Okay, more than double diabetes in the Indian population. And another problem in that the high hospitalizations and due to its complications among Indian population in hospital in Australia. In Australia, basically the healthcare is free. Basically, so you are going to see any doctor, or you want to go any investigation or any lab test, pharmacy, everything is free, is paid by the government. Okay, so if anything beyond limitations, so there is a unnecessary they are burden on the government basically. So, what is the patient preference? How we can measure this preference? So, USFDA basically give the definition. So, any new medicines basically in US, if going to be a market, before that they have to do a patient preference study. The main reason, for example, there is only already some treatment available for that particular condition or the disease, so they want to check the acceptance of the patient, whether patient want to use this medicine and what is the advantage, how much money they can pay. So there are several factors we analyze this kind of studies. And so like we can be like a qualitative and quantitative assessment of the relative desirability or accessibility to patient of a specified alternatives or choice outcome or attributes. So basically simply we give 2 3 choice to a patient or 4 5 choice to a patient, and patient will choose out of them one, and 1 2 3, and then we will see the why he choose this one, what are the factors are affecting when he choosing a one. So there is some factors, for example the cost, maybe the effectiveness, maybe the side effect of the medicine. So there are so many factors we consider for the. So this can be measured basically quantitatively or qualitatively easily. And then there are, the patient preference information can identify the outcomes are most important assets, So this is like a personalized medicine. So the patient basically seeing that, this is the important for me. Side effects are very, very important for me. Or maybe it is like, that the effectiveness of the medicine is very important for me. Or maybe the affordability of the medicine or important for me. So it's like a personalized a factor for each patient, and all the clinical guidelines basically worldwide they are using the patient preference. And preference are the impact on medication adherence. If the medicines are choice of a patient, so automatically the adherence improves. And if medication adherence is improved, so the outcome automatically improve, and we can reduce the cost of the for the patient. And patient preference use evidence-based regulatory decisions. Yes, as I told you that some of the regulatory bodies, before they make a decision to give the approval for any kind of formulation to market, and they have to see, if there is a patient preference is high, so they give the preference for this medicine to give the permission so they can market in the market. So the method basically we can use the online survey, or also we can do one-on-one interviews for a patient, and then we can give them the questionnaire and they can fill in individually. So I personally use basically online survey because this population are not available in particular hospital or maybe like a particular area, because Indians are living in Australia around Australia, so it's very difficult to find some patients, so we do this online survey. But if you are doing this kind of study in any hospital or any clinic, then you can use individual interviews as well. So discrete choice experiment basically we use basically the Qualtrics or online survey, or you can use whatever you want. Qualtrics is a paid survey, but you can use like Google survey as well, free of cost. So these are the factors we choose. These are the factors basically we were analyzing. First of the side effect of the medication. So we asked them like mild, severe, or moderate, and then we asked them the effectiveness, especially the HB1LC, or number of times, how many times they need to take medications, or these are formulations, like a tablet or a powder form, liquid form, or instruction for taking like before food, after food, and hypoglycemic events also very important factor in the diabetes, and weight changes. As you know, a lot of the diabetes medications are increase the body weight. We also see this is a factor, important factor, and of course, the cost is also one of the important factor for the many low and middle income countries, especially. So we also give them the these are the factors. So this is the choice we give. So this is like a software, and there is some specific analysis for that. So the software will analyze and give to them the particular patient. So what we do, we just make for three sets of these factors, and then the software will do. That's the thing. So some patient might be, he will give like moderate improvement. Maybe for next patient he will give that the high improvement. Another patient might be, he can give like mild improvement. So he will change all those things. So based on these factors, patient will read and he will select that the medication. This conventional medication or Ayurvedic medicine patient want to use, or no medication want to use. So we basically give the three choice for a patient. That conventional medicine, for example, like metformin, or Ayurvedic medicine if they want to use, or no medication, which one they are going to. This is one of the choice example. So we do basically some testing before we give this survey to a patient. So we did basically two patients with diabetes and two Indian migrants without diabetes, and we ask them the questions. We take some feedback. We also do some survey with some of the researchers. So we did some modification as per their feedback. So sometimes we use a lot of difficult terminologies, so we little bit like in the lay personal language, so easily understand by the patient, and they can read and understand what we are trying to achieve from this study. And then we recruit the patient online, and there is a lot of advertisement on the Google and Facebook and all those things, and we got very good response, and study was completed. It's already published. Basically, these articles, I think three, four articles already published. So these are the results we found. So these are the here are the attributes we was analyzing, coefficient and standard error and all those things. So we will see basically the patient gave the preference for which factor more. For example, effectiveness, side effect, formulation, or instruction with food, hypoglycemic event, or the weight change. So these are six are the basically significant. These six factors very significant for a patient. The cost is not significant in Australia, obviously, because there is a free of the medications. Everything is free because paid by the government. It's a high income country, so people don't care about the money. They just want to take the best treatment or best medication. So here are six parameters are very important for a patient perspective. But in this also, if you see that relative importance of attributes, so the hypoglycemic event. So most of the patients who are diabetes and some, this very, very frequently they got hypoglycemic events, and sometimes they need to take some, like sugar and all those things, maybe the chocolate to improve their sugar level. So in that, they give the highest preference for this, and number two, they give the weight gain. So as you know, the metformin only not increase the body weight, and otherwise most of the medications are increase the body weight for diabetes patients. And third factor was that effectiveness, and then followed by the interaction with food, then side effect, and then the formulations at least. So patient preference is a key role in the future of diabetes care. So we must include especially in the personalized medication care or in the clinical practice, or maybe in our, if we are to have some formulary in our own hospital, or maybe if we have some standard treatment guideline to treat diabetes in our hospital, so we can use or we can implement this kind of things. Okay. So and another thing like CPG. Clinical practice guidelines, informing decision, and again the regulatory bodies also can take a decision based on this patient preference. Impact of patient preference and adherence therapy. So obviously, as I told, so there is some studies told that 45% of diabetes they are failed to achieve adequate glycemic control because they are not adhered to the therapy. So if they are using as per their preference, obviously they will increase the patient preference, and we can reduce the complications for diabetes patients. And evidence for informing regulatory decisions, as I told that lots of like nice guideline in UK, in Australia also they consider. For many other countries, they are seeing basically health technology assessment (HTS), and they see the harm and benefit of this, and then they give the approval. So same for the TGA in Australia, but in India, and UDA just CDSCO not yet they are not taking any consideration for this, but in future maybe they will also follow because all high income countries nowadays they are following the patient preference. The data, and then they give the approval for the medication or decline the medication approval. So in conclusion, that aligning healthcare policy with could improve the effectiveness of healthcare intervention by improving adaptation or satisfaction. So obviously, we are taking the medication we are given as per their preference. So adherence will increase, or their satisfaction of the patient will be increased. Okay, and then so these three important factors like preferences of patient will be measured and reflected to inform individual treatment decisions in clinical practice. Or incorporating patient preferences is the next step in clinical guideline, and evidence on patient perspective will be part of the regulatory approval in the future. So in the future, basically, any medications or any device going to approve in any country, so most likely they will see the evidence from a patient preference before they give the approval. So this is overall conclusion. This is for the study conclusion. So patient basically study found that negative preference for the both conventional and negative patient. So it means that the patient do not want to use any medication, whether it is conventional or Ayurvedic. They want to just without medication if they can control the blood sugar, but unfortunately it is not possible. But Indian migrant, but most likely not to start is a conventional Ayurvedic. मतलब वो दोनों ही medication they do not want to start. Okay, and the study found the preference for the conventional medication as per the Ayurvedic medicine heterogeneous influenced by several factors. So there is this is not we can say like specific factors are influencing for them, but most of the patients are give the preference for the conventional medication or allopathic medication over the Ayurvedic medicine in Australia. And potentially experiencing hypoglycemic event was the most important and influential factor to Indian migrant, followed by weight change and glycemic, like effectiveness, instruction for taking with food, and side effect and formulation of medication. However, in Indian migrant with diabetes indicated that preference for medication in order to gain the stated benefit despite mild or moderate side effects. So, they know all the medications have side effects, still they want to use the medication it needs. Is it therefore essential to identify factors that help the doctors to initiate medication effectively, to optimize treatment plan to use the medication in migrant type practice in Australia? So, since if you any question that we have, then I can cover here.
Sir, actually the question will be asked by audience. So it will be open for audience. They put the question in the chat box. We will reply after discussion with the expert. So it is an open
Basically,
house. So you can
we are basically, we are there is no audience basically. These are from our academically guys.
Sir,
So
actually, sir, actually it will be released on our platform. After releasing,
yes, so
if we
maybe if they
receive any
ask,
query,
maybe I will try to answer. Yeah.
yes, yes, sir. So I will convey you and accordingly reply to the audience. So thanks,
Okay.
sir, for
Sure, sir.
your excellent talk on patient references, measurement, application in clinical practice. And thanks, sir, for sparing your valuable time at ISFCP 101 dialogue series. Thanks ISFCP management and team academically, and our director sir, IQAC coordinator Dr. Siddharth Mehan, our IT team for organizing and smooth conduction of ISFCP 101 dialogue series. Thank you all for being with us at ISFCP online platform. Thanks again, sir, for being with us. Thanks, sir.
Thank you. Thank you, son. Bye.
Bye, sir. Bye. Thank you.
So can you please can we stop recording?
Yes, sir. Stop. Done.
Sir, I think he left the meeting. So once we left the meeting, that the recording will be automatically stopped.
You can ping him, Sadiq. You can ping him. He can.
Okay.
Stop. No.
Okay, maybe we can discuss in our. I'm giving you another link.